Okay. I'm just introducing the complement of myself. First, thank you to the organizing committee. Thank you, Professor Fabi, to stay here with us. It's an honor for me. And I'm a surgeon, general surgeon, gastric and bariatric and metabolic surgeon. I operate in a Syro-Libanese and organizing hospital. It's a two private hospital and the best one in all South America. And I'm a professor of medicine in the University of Sao Paulo in the Department of Human Anatomy. And I teach a class in research, principles and practice in Harvard Medical School. My presentation is probably complement the other two, and it's a legal part of the Professor Fabi told you. So I talked about the sleeve gastrectomy. It's surgery based starting something 2005, 2004, based in the study of reline that started in 1999. So it's scientific comprobations about this reline substance. This is the proposal of my presentation. I proposed a modification of the surgery that starts with Michel Beignet, the sleeve gastrectomy, and I demonstrate what the difference that I propose and what I do. We start the schedule in 2009, but we have patients that have now more than 5 years in follow-up. Really, we start this operation when it was approved in 2004. I have no scope. In the United States, we have more than 56% of kids, children with obesity. It's 1/30% of the U.S. adult patients have obesity. And this 50%, it's severe obesity. In Brazil, more than 6 million persons stay with obesity. It's very important because surgery, as in SAGES, Society of American Gastroenterological Surgeons, and NIH prove and comment, is the really only way to loss and effective loss weight and maintain this control of weight. Recently, Philip Schauer from Cleveland Clinic, Ohio, published in a Schauer published in New England. New England. Yeah, it's a publication that compared the drug treatment of diabetes and obesity and surgical treatment, and it's proved a long time. It's the surgery provides better conditions about loss weight and about the control of diabetes disease. It's a very important question, and because we have millions and millions of humans stay in an overweight, obesity, and sometimes severe obesity condition. And it costs to the health insurance or the government more than $5 billion. More important than it is the health of the persons is really a fact. Human stay to last life, health, with very, very small cost. Food. Food is responsible for it. And we have food where we are. This for long-term studies demonstrate if you submit people to a no-operative treatment, the average weight loss is less than 5% during this period analysis of this study. Switzer study with 10 years time showed that the medical management obtained 1.6% of successful. Gas prevent, that I think that we didn't do more in Brazil, and now it's a fewer here in the United States since 2008, when FDA approved the use of gas prevent, just started in 2008 in the United States. Really, the results is not so expressive. Gastric bypass, this is a very, very long survey that procedure that start probably the main important procedure has a 25% in global results. So with the advent of minor invasive surgery in 1988, and after use in a metabolic and bariatric surgery, the results of surgery has a very significant and sustainable results, because it's a very significant and sustainable weight loss. In the United States, we have a progress of these people, patients that was submit bariatric surgery. And now more than 300,000 victims occur per year because of the obesity. So obesity is projected to overtake smoking as the main cause of death in the next years. Our method of the study is a prospective randomized double-blind sample-size trial, one dependent and one independent variable, one tailored test and t-test, and parameter subject with linear regression. The contraindications really is not absolute contraindications. We have some others relatives, but this one is a severe heart failure, unstable coronary artery disease, and stable lung disease, of course, active cancer, until severe intellectual capacity. Because when you submit a person to the patient to the bariatric surgery, you need to explain something before and a lot of things after. So this patient is very important, a very good mental condition. In the great part of the service of surgery, a multidisciplinary action with a very good nurse that studied bariatric and diabetes metabolic surgery, a psychologist, a psychiatrist, and nutrologist, all of them. It's very important to clarify the patient what really happened and what need to do after. In this study, it's 150 patients. This mean BMI is a 44.5. The diabetes patient need to have more than 10 years in diabetic care. We obtain more than 85% of control of diabetes in a period of 2 years. 84% of control of cholesterol and 68% of hypertension. Something that you need to talk about is about the calcium, vitamins, and magnesium, because this surgery, this lead gastrectomy, is not a disobservable surgery. So we don't put our hands in the gut. So the absorption of the nutrients is totally okay, is normal, is physiological, because sleeve gastrectomy do the operation just in the stomach. We had some problems with zinc, because just 10–14% of the patients, and mainly in females, have under a low tax of zinc. But you can take zinc, you can offer zinc and vitamin B2 to these patients, and 6 or 8 months after the zinc tax is okay. The problem that the problem that occurs with the slower checks of zinc is the hair loss. It's because zinc when loss is very important to the growth of the hair in a patient. The inclusion criteria is peptide C more than 1, of course, because it's strictly, directly in accordance with the capacity of the patient to produce insulin. When you have peptide C more than 1, this patient is a residual producer of insulin. Anti-GID, it's glutamic acid decarboxylase, need to say negative, because if you have antibody to get the GID, you can't produce insulin, because GID is the responsible to stimulate the cells in the pancreas, the bad cells, to produce insulin. And anti-insulin, of course, if you have anticorp to insulin, you can do anything. It's a diabetes type 1. It's autoimmune diabetes. And the other things, documentate insulin glycate more than 6.5% at least 3 months. And the patient in use of anti-diabetic drugs or insulin treatment. The age is very important. We stopped the study with patients older than 70 years old and no less than 21 years old. This is the distribution of the patient in this condition in a diabetes type 2, use or not use insulin, and the BMI distribution. The average of this is glycemia about 206 in the average, in the median. We have a patient with 800 glycemics out of diabetes coma. So it's a 10.1 HbA1, peptide C 2.6 is the median, and all of the, I talked about the other ones negative, and BMI, the average is 40.2. This is the BMI 12 months and 30 months, the average lost weight. It's very significant. I know it's very difficult to talk with the people who don't do surgery, but you can believe this. The glucose index is 86% of the patients less than 99. So the patient stopped to use the drugs for diabetes and stay at normal glucose index. 8.7%, it's 100 to 106, and 5% of the patients still taking medicaments. This is the same percent in the total. The evolution of surgical options started in 1954 with jejunal bypass. Some, of course, all the studies, some complications we expect, but now the gastric bypass, the last 25 years is the most important surgery, and we started there as sleeve gastrectomy in 2005 with good results. The options of this, the laparoscopic sleeve gastrectomy, you can use this as a first stage of a duodenal switch. You have a very super obese patient. You can do this sleeve gastrectomy, the first operation. And after, if you need to lose more weight, the patient needs to lose more weight, you can do a duodenal switch. It's another modality of surgery. But in great part of the patients, laparoscopic sleeve gastrectomy demonstrate that reduced weight, then the patient want and the doctor thinks better to this patient. And the great part of the patient don't need to do the sleep, do the now switch. This is the proposal of the surgery. The traditional sleeve gastrectomy is this red line. It's a vertical standard gastrectomy. We decided to approximate, to maintain the curve, the anatomic curve of the great curve of the stomach, and go to 2 centimeters to the pylora, to the anatomic pylora, because they still prove that in this region of the antrum, in this part, where is my here? In this part, we have the cells that the cells will produce ghrelin. In this part of the stomach, stay 8% of the ghrelin that was produced in the body. The other part, the 20%, stay in a pituitary gland, like hypophyse, in a adrenal gland, in a duodenum, and a little part in the pancreas. But 80% of the ghrelin production in the body is in this part of the stomach. So, because of this, we propose this complementation of the surgery. This is a study that demonstrates the occurrence of the ghrelin cells in the antrum, so because of that we decided to modify the original surgery. Oops. This is the result. The video pancreatic derivations, video pancreatic surgery. This is the duodenal suite. You can have almost 100% of resolution of diabetes. It's a reality. It's a totally scientific proof. The laparoscopic gastric bypass, it's a better result after the sleeve, after the video pancreatic. And the sleeve is staying in the median of this. It's a good proposal, and the advantage is you don't put your hands in the gut. The intestines of the patient. You don't do any bypass. Just operate the stomach. The base of the surgery is take out the 8% of the ghrelin out of the body. Because because when you do this, your results is very favorable. And that I told before, if the patient has regain of the weight, or if you have tumors of the hepatic pancreatic system, or pancreatic tumors, you can abort this patient, operate this patient, and complement the surgery with duodenal suite, for example. The proposal of the surgery is based in a vacuum based on the resection of 8% of ghrelin in the gastric area, because this is responsible, ghrelin, to the action in the hypothalamic cerebral point that is responsible to hungry, it is responsible to compulsion to it. This is the example and why it's occurred. Ghrelin actions is stricter way to eating compulsion in the nucleus of a suprathalamic nucleus, is responsible to allow gastric emptying, and is responsible to blockade the insulin action. So when you take out 8% of the production of the ghrelin, and the patient, of course, if you operate the patient because he has this condition, the patient has a peptide sign more than 1, so he has production, she has production of residual insulin. When you take out the ghrelin, you have this, the patient has this insulin that he really produced free to action. It's the other proposition, and the other cause that we the proposition of the sleeve gastrectomy. And this is the evolution of the surgery, the actions that I told. The system, the representative system, the action of ghrelin in a hypothalamus is responsible to stimulate the appetite. And the comorbidity that occur that everyone knows. The results of preoperatory hypertension is present in 72% of the patients. After surgery, we have the control in 68% of the patients with a good blood pressure. Sometimes 25–30% is still to use the hypertensive drugs. The justification of the surgery is it's really the weight loss is more effective and sustainable with the surgery. This is approved. And in diabetes condition, diabetes type 2, we show that more than 80% the patient has a control. Stop to use the drugs, stop to use the insulin when he has a diabetes type 2. The results in a metabolic syndrome, that's very important because a straight relation with heart failures and vascular disease. And 78% of the patients, in a case of dementia, it's the centimeter of the abdominal circumference is very fast. In 6 months, better, much better. Hepatic steatose is very important because I know how NASH goes. I recommend that the sleeve gastrectomy, sure, other surgeries, bariatric surgery too. If the patient's alcohol dependent, a frequent use of alcohol is not really dependent, but it's a frequent use. Drug dependence is significant physiological disease. This is an example of the hemoglobin glycate, the fasting glycemia, it's lower, very low, and the postprandial glycemia and the surgery, and the excess body weight loss. Some patients in 2 years, it's almost 60% of the loss. About the laparoscopic sleeve gastrectomy, it's a more complicated, it's not easy surgery like something think. It's a dangerous surgery. It's more difficult because you have a resection of 30 centimeters of the stomach. You depend on the stapler that you use. You depend on the vascularization of the patient in his stomach. So you have a serious complication, leaks, fistula of the end of the wrist. It's a very dangerous complication. Here's the statistic of complications. This is a very short 1 minute.
You used 30 minutes of your time.
Yeah, I know.
You got 20, you used 30,
Yeah.
it's too long.
Yeah.
Okay.
This is one of the results in 5 years in a woman. This is a man that will operate. It's a 552 BMI. This is the after 5 years. This is the tube that he used. It's a bougie. This the stomach, the specimen with almost 1 liter. This is the oral contrast before we start the diet, the oral diet. Sorry. This is the conclusion, the weight control in 87, low. This is to think about the heavy and the lightweight. The thin person is not really more good person, or really you need to think it's not a competition, it's a health. So you want to patient have a thin patient or no diabetic patient because of the health, not a competition. And this bariatric surgery is totally indicated in this case. Thank you.
Thank you very much. You had a